Chapter 49 is entitled Nursing Care of the Child with a Neurological Disorder. The first topic covered in Chapter 49, or that I'd like to cover with our PowerPoint, is increased intracranial pressure. Now, we talked about increased intracranial pressure during week 1 when we were talking about hydrocephalus, and we had talked a little bit about treatment of hydrocephalus with a VP shunt. This particular topic is just expanded on a little bit in Chapter 49. Certainly, hydrocephalus can be one of the causes of increased intracranial pressure. Again, this chapter gives you some other causes for increased intracranial pressure. Again, it could be a tumor is present or some other type of lesion that's taking up space within the skull. Again, with hydrocephalus, it could be an accumulation of some CSF fluid. There could be some intracranial bleeding, or some edema of the cerebral tissues. Meningitis, which we're going to talk about also in this chapter, can be another cause of increased intracranial pressure. As far as assessment and signs and symptoms that you might notice in a child experiencing increased intracranial pressure, if you look at the table on page 1550, it gives you some signs and symptoms. Again, increasing head circumference. We're only talking about that, though, and the fontanelle changes as well in that child who is still young. Remember that anterior fontanelle will usually close by about 15 months of age, so then we wouldn't really notice those two signs and symptoms if we're talking about an older child. Vomiting, and again, just to make note there, especially if it's just vomiting upon awakening in the morning, vomiting in which the child does not report any nausea, as it says in your textbook. Oftentimes a sign, we see that a lot with brain tumors. Pupil changes, vital sign changes, pain, and then certainly alterations in level of consciousness would be some other signs and symptoms. So again, it's outlined well there in table 49.3 on page 1550 in your textbook. Managing a child with increased intracranial pressure. Obviously, the one thing we do have to think about is determining the cause of the increased intracranial pressure, and then, if possible, working to alleviate whatever the cause or the etiology is for that increased ICP. But just in general, some of the therapeutic management that we think about for a child with increased intracranial pressure, a few of the things I have listed on your slide and that are also addressed in your textbook on page 1551, making sure that we're preventing overhydration or underhydration because we want to maintain adequate cerebral perfusion pressure. It's important that we don't overhydrate the child because that could cause some increase in intracranial pressure. So making sure fluids are running at their maintenance would be appropriate. Positioning, again, we usually think about putting them in a semi-Fowler's position. Osmotic diuretics, such as mannitol, also again to treat the cerebral edema, to remove the fluid, and then to treat the cerebral edema, we'd usually see Decadron being used as well. Other things to think about, trying to promote normal bowel elimination as well, because we don't want any straining if they were trying to pass a stool. We have to think about mechanical ventilation, if that's occurring as well, possibly hyperventilating the child. That may also help to decrease some of that intracranial pressure. The next topic that I'd like to discuss from this chapter is cerebral palsy, or sometimes just referred to as CP. I have the definition here up on your slide: a non-progressive motor and posture dysfunction that occurs secondary to anoxic damage in the motor centers of the brain during the prenatal, perinatal, or postnatal period. Typically what we think about with CP is that the child has had some type of hypoxic episode. Again, generally we think about that as maybe with a traumatic birth, but as you can see by the definition, it really does include any of those hypoxic events that could have happened before, during, or even after birth. We see that the incidence of children with cerebral palsy is increasing. This may be attributed to increased survival rate among infants who are born very premature. Technology today is allowing those infants to survive, but again, one of the possible complications of that may be cerebral palsy. There are a variety or varying degrees of how a child can be affected with CP. Some children may be affected only very mildly, and again, to just look in a crowd of children, you may not even be able to pick those children out who are very mildly affected. Then we could go to the opposite end of the spectrum and see those children who are very severely affected, who are nonverbal, non-ambulatory, may have seizure disorders, feeding issues, a lot of cognitive deficits and delays as well. So again, CP may look different in each client that you care for. One thing that I always do like to say as we're starting a discussion of cerebral palsy is that cerebral palsy does not necessarily mean that a child is going to have any cognitive deficits. I think as nurses, oftentimes the patients that we come in contact with who have CP are kind of at that more severe end of the spectrum where they may have seizure disorders and lots of health issues. And oftentimes those that we see do have varying degrees of mental retardation. But a diagnosis of CP in and of itself does not indicate that there would be any cognitive deficits or delays. So again, just something to keep in mind. You know, I always say a person could have CP and be the proverbial rocket scientist. So again, just to emphasize that, because I know as nurses, oftentimes those patients that we see are going to kind of, again, be at that more severe end of the spectrum. Just if we're thinking about across the board, what are some commonalities with children with CP? Oftentimes speech difficulties, swallowing difficulties. Certainly there is an increased incidence of seizures in children who have CP as well. Again, not that every child with CP is going to have a seizure disorder, but there is that increased incidence within that population. Clinical manifestations. As I say on the slide there, this can vary with age. Thinking about the young infant from birth to about 3 months of age, what are some things that we might notice that might raise that red flag that perhaps this child has CP? Again, problems with feeding, very weak sucking, poor swallowing reflexes. We may be looking at hypotonia, where the child may have difficulty. Probably one of the first things we might notice is head control. Another thing would be some persistence of their neonatal reflexes. With CP, one of the things that we notice is, and again, if you haven't had OB, you'll learn more about this during that particular course, but we know some of those newborn reflexes like the startle reflex and the palmar grasp reflex and Babinski reflex and all those things, rooting, that are normal in an infant, but as that child develops, we see some of those reflexes disappear. When we're seeing those reflexes still present in a child well beyond when they should have disappeared, again, that may be an indication that the child has CP. As the child grows, things that we're also going to be looking for, some delays in meeting some of those developmental milestones, thinking about, the child who is 8 or 9 months of age and isn't sitting by themselves. We may also see some development of some hypertonicity as well, or where they just have real increase in their muscle tone. That's also very common. Again, continuing on, if we had a child who was ambulatory, some other things that we might notice is things with their gait. Oftentimes children with CP have what is called like a scissor-like gait. Their adductor muscles and their hips tend to be very tight. So their legs will kind of cross over each other when they're walking. You may also notice that a child or individual with CP may walk on their toes because those heel cords tend to be very tight. As far as diagnosis, I should say, there's really no blood test that we can run for CP. Diagnosis is based basically on the child's clinical symptoms that they present with, as well as looking at their birth history, their health history, again looking for any signs that there may have been some trauma or some hypoxic episode that could have brought the CP on. But that's kind of the frustrating thing too, is that we can't have a definitive, just a blood test. And a lot of times if we're noticing a few things when the child is young, you know, those things may change as the child gets a little bit older. Doctors may be hesitant to say, well, this is CP in a child who's only 2 months old, may want to take a wait and see approach, and that can be frustrating for parents. Just to look at this case study here, it says Tasha is a 2-year-old girl who has just been diagnosed with CP. Her parents are visibly upset by this information. Her father says, "My poor little girl, what's going to happen to her? What are we going to do?" Mom asks, "How can we take care of her?" Parents are concerned about long-term problems. Would you encourage them to concentrate on these or on more short-term concerns? And so again, just I guess in general, what could we think about this case study, or kind of thinking about some of the questions that are answered? Certainly, you know, although this child's disease has just been diagnosed, it's likely that the parents may have been aware for some time that their child was not accomplishing motor tasks, or that there were health issues. CP isn't something that all of a sudden a child who's been developing normally until, 2 years of age, all of a sudden starts displaying signs and symptoms. Again, unless there had been some type of traumatic event. Certainly the parents are upset. So exploring with them how they feel that the illness will affect their daughter, what they feel will be their major care problems would certainly be important. I think in these early stages, giving them information as they're, kind of use them as a guide as far as what information they need. They may need to, at this point, just focus on day to day. Certainly kids with CP, there are different challenges, as the child grows. A lot of times they may hit some of those developmental milestones that, even though they haven't hit them at the time we thought they would, down the road we may see them, a child may be isn't walking by a year or 15 months of age, but maybe by the time they're 3, with the use of some assistive devices and therapy, we may get them to walking. So that's probably the other frustrating thing for parents, is that we can't tell them exactly what the course is going to be. A lot of times it's just providing those supportive type therapies and seeing how the child does. Just a few things to think about in general with nursing care for a child with CP. I put nutrition on there again because we said earlier that a lot of times swallowing difficulties are very common in children with CP. So what are some specific interventions we could employ in this situation? High-calorie diets, maybe supplements as well, additives to the food like a Duocal or something like that to boost up the caloric content of what the child is taking in. Soft foods, the type of food that we're offering. The picture there on your slide is kind of showing the caregiver providing what would be called manual jaw control and support when feeding a child with CP. Those of you who are at PPC for clinicals probably have seen a lot of children there with CP, and you may have actually seen or participated in feeding children with CP, and so you certainly can recognize some of the unique challenges for a child with CP. It may be that the child isn't going to be able to take in enough nutrition by mouth to sustain adequate growth. There may be that small percentage of children with CP who end up with a G-tube. Now, it may be the G-tube is for all of their nutritional needs, or it may be we just use the G-tube to supplement, allowing them to take in what they can PO and then supplementing with G-tube feedings. Certainly physical mobility is important as well. Range of motion exercises are important to maintain joint flexibility and prevent contractures. Physical therapy would certainly be appropriate here, as would speech therapy, especially with the swallowing difficulties. Occupational therapy as well may come into play. You may see children with CP using AFOs, or ankle foot orthotics. They may be using walkers or other types of braces. Some may be confined to wheelchairs. Again, so we want to promote what physical ability the child has and kind of work from there. Safety issues come into play. Again, I mentioned earlier the increased incidence of seizures in children with CP, so seizure precautions are always appropriate in this instance. The gait difficulties may increase the likelihood of falls in this population. Emotional support for the child as well as the parents. Again, this is a chronic illness. This is not something the child will outgrow. They're probably always going to have some clinical manifestations of CP throughout their life. The parents are going to face new challenges. It's one thing when you have a child who is 2 years old and weighs 30 pounds and is non-ambulatory, caring for them up and down the stairs, bathing them, transporting them to doctor's appointments, to the mall, out to eat on family outings. It becomes a whole different set of challenges when that child is 12 years old and weighs 100 pounds and is non-ambulatory. So again, it's just, over time you'll see that parents are continually facing new challenges. Again, parents, we'll talk more about the effects of chronic illness during week 5. But again, just, the financial strains, frequent hospitalizations, all those issues come into play. And again, you have a nice care plan for a child with CP in your textbook on pages 1556 and 1557. The next topic is bacterial meningitis. And again, meningitis is an infection of the meninges, typically caused by bacteria invading the central nervous system. Sometimes it can be viral in nature, but certainly the bacterial meningitis can be fatal in some instances if it's not treated immediately. So those cases that we often hear about in the newspaper typically are bacterial meningitis. How does a child get meningitis? I guess I should back up. What would be some causes? For quite a while, Haemophilus influenza type B was a common causative agent of meningitis in young children. That now is not so much a common causative agent, because you probably know why from last week's readings that Hib vaccine, or that we're actually vaccinating against Haemophilus influenza type B as well. Now we see pneumococcal as being another common causative agent, but we have a vaccine now that children are getting with that as well, that Prevnar vaccine. So again, what is typically happening with bacterial meningitis is that bacteria gets into the meninges, maybe through the bloodstream, and spreads through the CSF fluid. A lot of times it might be a child who's had some type of upper respiratory infection. Oftentimes that may contribute to that. Or it may be some type of trauma, maybe a skull fracture or something, but that bacteria invades that central nervous system. And again, that cerebral meninge starts to become very irritated and inflamed. So what are some of the clinical manifestations or signs and symptoms that we might see the child present with? In younger children, again, a lot of it's going to be some of those going back to some of those signs and symptoms of increased intracranial pressure, because that's what really is happening here. We're having an inflammation. We may start to see irritability, high-pitched cry, bulging fontanelle. A child who, usually we think about a child who, especially an infant who's fussy, irritable, picking them up, holding them, rocking them, patting them. You know how the moms are always kind of holding the babies and bouncing side to side. A child who is having increased intracranial pressure, that is not going to soothe them at all. In fact, it may even be more irritating to them. They may find that the child is a little bit less irritable being left alone versus being held and handled and rocked. An older child, some of the things one of the classic signs we think about is nuchal rigidity or a stiff neck, headache, or just complaining that their head's hurting, maybe some vision changes, again, probably some irritability as well. This picture here comes from your textbook on page 1559. I just included it here just to point out it shows the nurse examining the child for Brudzinski's sign and Koenig's sign. And again, I know on this slide you can't necessarily read the description, but in your textbook you'll be able to see that again on page 1559. With Brudzinski's sign, the top two pictures, again, flexion of the knees and hips when the neck is flexed, with the child laying in a supine position. So you can see, start with the child laying flat, ask them to bring up their head, and the child will instinctively pull up their knees and hips as they're doing in that picture in the top right hand corner. Again, that would indicate a positive sign. Koenig's sign on the bottom, again, you can see the child laying flat on the exam table, and as you're kind of flexing the knee there, or the lower leg, and then extending it, if we see a lot of pain and resistance with that knee extension, again, that would be a positive sign indicative of meningitis. Treating of bacterial meningitis, antibiotics will be prescribed. Steroids, osmotic diuretics, again, just for the same reason they were with the increased intracranial pressure, again, because we're also having some of that cerebral edema occurring. The child would need to be in isolation with respiratory precautions for at least 24 to 48 hours after antibiotics have been administered. Once the child has been on antibiotics for, generally they'll say 24 hours, they would no longer be infectious. As a rule of thumb, in the hospital, you may see that isolation extending beyond that 24-hour period, but in general, we think about, going by the books, they need to be in isolation for until they've been on antibiotics for 24 hours. Monitoring respiratory and neurological status, again, monitoring level of consciousness, and looking for all those signs that may indicate there's some increased intracranial pressure. Promoting comfort, again, because oftentimes they have a stiff neck, so allowing them to assume a position of comfort. Keeping the room quiet, decreasing environmental stimuli. We probably would want to have more dim lighting in the room. You don't want to rush in there and just whip open the curtains in the morning and let the sun come shining in through the windows. Probably won't be appreciated by the child who has meningitis. And again, you have a nice care plan outlining some of those nursing interventions in your textbook on pages 1559 and 1560. Now here's just a question to think about for a child who has bacterial meningitis, 2-year-old, severe neck pain when she's moved. Mom says, doesn't want you to worry so much about her intake and output, let her daughter rest. How might you answer her? Then it says, suppose you cause call the child's name and she doesn't answer you. Why is this a particular cause of concern for a child with meningitis? Well, certainly we know that the meningeal irritation is causing some pain when that neck is flexed, so that neck pain, or again nuchal rigidity, neck stiffness, is a common symptom of meningitis. But measuring I&O is very important in our plan of care for a child with meningitis, because we may see as a complication with this disease either overstimulation or understimulation of the pituitary gland. So we may either get an overproduction or underproduction of antidiuretic hormone. So monitoring the child's I's and O's are very important. Additionally, we talked about with increased intracranial pressure, making sure that we are keeping the child hydrated and not overhydrating or underhydrating them. So keeping good track of their I&O is very important, and we'd probably have to explain this to the mother as well, that we understand the child's need to get rest, but it's also important that we're keeping the child safe. As far as calling the child's name and she doesn't answer you, certainly we'd have to think about one complication sometimes can be hearing impairment. So we may need to check to see if that's the problem. Our other concern certainly would be, has there been a change in level of consciousness? So frequent, thorough neurochecks are also going to be very appropriate in this instance. Okay, now just to talk a little bit about Reye's syndrome. I'm sure you probably have heard of Reye's syndrome before, especially if you have children of your own, because you've probably heard, if you have children of your own, that you're not supposed to give them aspirin because that may cause Reye's syndrome, and that is true. A brief description of Reye's syndrome: it's kind of a multi-system disorder, typically following a viral infection. And the viral infection that we think about most often has been chickenpox. And again, also thinking about the cause, aspirin use in a child with a viral infection has been one of the more common etiologies in the Reye's syndrome cases that have been seen. There has been a very good public awareness campaign about the dangers of giving children aspirin products. So we really have seen a decrease in the number of Reye's syndrome cases that are presenting themselves. If we do get a child in with Reye's syndrome, it's important to note that early detection and management is crucial, because the disease can progress fairly rapidly and can result in death. As far as clinical manifestations, they'll usually stage the child. There are about 5 stages that they go through. You don't have to worry about what happens in each of those stages. But again, just know that through each stage, the child's condition is getting progressively worse. And again, starting with perhaps just some lethargy, confusion, to the last stage where we would have seizures, possible respiratory arrest, and again, then perhaps even death. Basically, it's a disease involving the brain. Encephalopathy, liver involvement also occurs. We'll see cerebral edema occurring. May also see effects on the kidneys as well as the heart. So again, what are our nursing management? You can review what's included in your textbook as well, but certainly, again, rapid assessment and management intervention is appropriate. This is a child who's going to be in the intensive care setting. Monitoring for increased intracranial pressure. It's likely they may even put them in like a drug-induced coma as well. During the treatment stages, maintaining a patent airway. Obviously, they're going to be on a ventilator if they're in that drug-induced coma. Monitoring temperature, hypothermia can be a problem. Again, definitely a very intense situation, but luckily not one that we are seeing that often anymore because of making the public aware of the importance of not giving aspirin products to children. So to look at the question that's on your slide here, it says a high school senior who is your neighbor tells you he thinks he has the flu and he took some aspirin for it. When you tell him it's not wise for children to take aspirin for flu-like symptoms, he tells you that advice is just for babies. How would you respond? How would you pursue the matter with him? Well, again, typically we think about 18 and under, that they should not, are still in that risk category, shouldn't be taking aspirin for flu-like products. But some studies even show that that age limit should really even go through young adulthood up to about age 25. So again, certainly thinking about, there could be other alternatives that he could take, Tylenols, Motrin, ibuprofen, that may alleviate his symptoms. And again, just to stay away from that aspirin, being that he's kind of right on that cusp there as far as risk group for Reye syndrome. Now to talk a little bit about seizures, and I've listed the different types of seizures up here, and in your textbook, also on page 1563 in box 49.5, you have classifications of the different types of seizures. Questions that you're going to see on the exam would not really probably ask you to identify what a particular type of seizure was in terms of the clinical manifestations and what that would involve with the seizure. But again, you may want to focus more on care of the child with a seizure disorder. In general, if we have a child who has had 2 or more seizures of unexplained origin, they would be diagnosed as having a seizure disorder, or sometimes a term we might hear used as epilepsy. Again, 2 or more seizures of unidentified origin. In other words, we couldn't relate the seizure to perhaps, a febrile seizure, and we'll talk about febrile seizures in a little more detail in a minute. But the seizure isn't related to perhaps a trauma, a head injury, maybe an electrolyte imbalance, blood sugar issues, those types of things. Types and causes of seizures can vary with a child's age. I know a lot of times when we hear the word seizure, probably the first thing that comes to mind is that tonic-clonic, or what we used to call grand mal seizures. But oftentimes, especially with an infant, the seizure activity will not manifest itself in that way. Sometimes with especially with infants, it might just be kind of a rhythmic twitching of the wrist, or of the ankles perhaps, or the foot. But again, so just kind of to keep your mind open that not all seizures, especially in children, are going to be that tonic-clonic grand mal type seizure. As we look at the different age groups, we can think about what are some of the more likely causes of seizures. For infants, I talk about if you're seeing seizure activity in infants, 2 likely causes may be either that the child is hypoxic or perhaps hypoglycemic. Now again, that's not going to be the only 2 reasons that an infant would have a seizure, but probably those are 2 of the leading causes of seizures within that particular population. If we look at toddlers, then we're talking about that is a higher risk group for febrile seizures. And again, we're going to talk about febrile seizures in a minute. Poisonings, toddlers are the highest risk group for accidental poisonings, and we know many medications or substances that they could ingest may result in seizure activity. So again, there could be a variety of different causes, but if we're thinking about some of those things, it may be a little more prevalent. Once we kind of get beyond that toddler age, there could just, again, it could run the gamut in terms of what may be a particular cause for a seizure in a child, preschool and above. Thinking about if we have a child presenting themselves with that they've had a seizure, What are some things, in history taking, things that we'd want to ask about? Did the child have an aura? Some people with seizures may report auras. Again, it might be some kind of sensation, a smell, a taste, just a funny feeling that they get immediately preceding that seizure. Was there any loss of consciousness? Was the child or patient incontinent? Certainly history taking, other things we could think about, what was going on immediately preceding the seizure would be something else to think about. If we're looking at physical exam, what would be some things that we'd be wanting to assess here? Well, they probably do a CBC and blood chemistry. Again, we'd be looking for any types of electrolyte imbalances, signs or symptoms of infection that again may have precipitated the seizure activity. EEGs certainly are can be used as well to try to determine if there is seizure activity, what may be the cause of it, further evaluation on that. CT MRIs, again, something else to think about is, are the seizures being caused by some type of brain tumor, lesion? So we could use that as well, or something to consider with our part of our diagnostic workup. There are a variety of different anticonvulsant medications that can be used in children. You have a couple that are outlined in your textbook, and I would encourage you to read the information that's included with those. Tegretol is mentioned on page 1565. On page 1566, information on phenobarb, and on page 1567, some information on Dilantin. And I always, when we talk about these anticonvulsants, the one thing I always throw in there, just a little FYI with Dilantin, because it seems like whenever I'm looking at NCLEX review questions from textbooks and those types of things, if I see them asking a question about Dilantin, it usually has to do with teaching the individual who's on Dilantin about good oral care, because one of the side effects of Dilantin is gum hyperplasia, or overgrowth of the gum tissues. So it's very important to teach those individuals the importance of good oral hygiene, making sure they're getting their teeth cleaned, at least every 6 months, sometimes even more frequently. I know I've even seen on some insurance plans now that if someone is on one of these anticonvulsants that causes that gum hyperplasia, that they'll even pay for more than just your usual 2 cleanings per month that most insurance companies will pay for. So review those 3 anticonvulsant medications that are included in the chapter. Now this question here says, describe assessment data that would be helpful to obtain regarding a 4-year-old child who's admitted for possible seizure disorder. Well, what would be some of the things that the data that we'd want to collect? We'd want to find out what was the child's behavior before and during the seizure activity. When was the first seizure noted? How old was the child? Is there any common pattern with the seizures as far as time of day or activity that the child is engaging in? Perhaps any other clues as far as when the seizure activity occurs? Any factors that may be precipitating the seizure? At 4 years old, the child may or may not be able to describe any type of aura or sensory phenomena that they may experience. The duration and progression of the seizure, we'd want all that information. And then post-ictal, following the seizure, what are some of the behaviors that are noted in that post-ictal phase? The next case study talks about Amanda, who's 16 years old, recently diagnosed with epilepsy after experiencing a tonic-clonic seizure. She's in the 11th grade, is very active in extracurricular activities. She's begun taking an anticonvulsant and will return to school shortly. Discuss issues that may cause concern for Amanda and her family, and think about some educational needs. Well, Certainly the family's probably concerned about, the likelihood of subsequent seizures, how to protect Amanda from injury. So we'd have to go over, some of those safety issues with her. Talk to her parents and her teachers about what to do if she does have a seizure. Not forcing anything in her mouth or between her teeth. Turning her on her side, clearing the area of any objects that may cause her injury during the seizure. The other thing we think about with a 16-year-old who has a seizure disorder is driver's license. I believe in the state of Ohio you have to be seizure-free for 6 months, and you have to submit confirmation from your physicians regarding that. So, peer group and all those developmental things, that may be where her focus is. And so we'll have to kind of, discuss the safety issues with that and the importance of taking her medications and those types of things. She should have a medical alert bracelet on. Stressing to her the importance of complying with taking her medications as they're prescribed, not missing any doses. We'll probably have her in to monitor blood levels to make sure they're therapeutic. Emotional support also, maybe refer to support groups would be appropriate for both Amanda as well as her parents. Now we have another question here. I think this one comes from your textbook. What if a child with a history of seizures controlled with phenobarb is brought to the clinic and mom says he's been very sleepy, especially in school? She says she cut his phenobarb dose in half. How would you respond to this parent? Well, the parent's probably correct in assuming that perhaps the dose the child is getting is a little bit too high since they're sleepy and can't really function in school. But, cutting or stopping the dose may put the child more at risk for seizures. So the most appropriate thing we'd need to do is get the child in and have blood levels drawn so that we see if we're in the therapeutic range. And then mom needs to work with the physician as far as titrating that dose or maybe cutting that dose back if necessary. And then just some things with febrile seizures. Okay, again, with febrile seizures, typically we see this, the age range here could probably be as young as 6 months, probably through up through age 5. But generally we see this not going much past the preschool age range there. Again, it would probably be unusual, probably not unheard of, but unusual to see a child over the age of 5 experience a febrile seizure. Febrile seizures generally occur with a rapid rise in temperature. They usually manifest themselves in that tonic-clonic type pattern. Think about teaching or how do we handle this? Well, certainly teaching the parents about appropriate measures to take to keep a child's fever from spiking or getting too high, including antipyretics, cool cloths, those types of things. There does tend to be a familial history, so if parents had a history of febrile seizures, there's maybe a slight increased chance that their offspring may also experience febrile seizures. Probably rare that you would see a child who's had a febrile seizure go on anticonvulsant therapy. May be prescribed if there's been some maybe focal or prolonged seizure activity. Sometimes in children under a year of age, they may prescribe anticonvulsants, or if we see multiple seizures occurring within a 24-hour period. But again, those instances are probably going to be rare. As a general rule, we wouldn't see anticonvulsant therapy for febrile seizures. But again, certainly, important temperature control methods is one of your most